Our next guest is Dr. Rob Orman. Rob was texting Rob. He says he's ready. Yep, there he is. So Dr. Orman is a multiple award-winning educator and lecturer. If you're a clinician, you probably know Dr. Orman from EMRAP, where he's the host of Essentials of Emergency Medicine and the ERcast podcast, one of the most widely heard medical podcasts in the world. His new project is called Stimulus. I'm really excited, very stimulated by the thought of this new podcast, Rob. It's a podcast that breaks down principles and strategies and tactics for medical professionals on how to live better and how to practice better. We take excellent care of our patients, but we kind of have a communal blind side, and we forget to take excellent care of ourselves, and it's time to fix that. So Rob is a community emergency medicine physician. I remember when I was a resident, I was a big fan of Rob and his ERcast and all his educational products. I learned a tremendous amount from Rob, and now I consider him to be a close friend as well, or at least, I guess, moderate or mild friend. Rob, how would you characterize acquaintance?
Yeah, I think all of those will do, depending on the day.
I love the setup there, the Star Trek picture.
Oh yeah, yeah.
The blue shirt.
We got Spock, we got the boss, we got Freddie Mercury, and everybody's got all these. It's interesting to look at the backgrounds of what's going on. You had the speaker earlier with like that beautiful, 3-part flower background, and Andrew Weil had this huge room and in the office, and sometimes got the kids running in. I think that's been my favorite part of the conference so far, besides the fact that it's probably the most interesting fusion restaurant I've ever seen, with the hardcore emergency medicine and then the biohacking. What a delight.
Getting to peek into people's homes has been fun, or at least peek into their backyard.
When you say it that way, it sounds horrible. It sounds,
it's a little more creepy.
Just a little creepy.
So your work on ERcast has really kind of escalated logarithmically since the pandemic hit the U.S. You're really collating an incredible amount of information and keeping all of us ER doctors and those on the front lines informed. What's been your focus recently? How are you? You got a lot going on.
Hey, there's so much information out there. Right? I mean, like this conference just touches the surface. I mean, it's overwhelming. I'm overwhelmed, and it's like trying to drink from a fire hose if you want to absorb it all. So instead of going macro and saying, you need to know everything, I'm trying to go micro. And what I mean by that is, for the past several weeks, I've been pulling in by interviews, just, conversations or practices of doctors from the US and Canada, really as far as what they're seeing, how they're adapting, and if there's anything that looks like or that they feel is akin to a best practice, or at least a good practice. And sometimes that's me seeing something that they do on Twitter, or they'll reach out and say, hey, we're doing this really well. And to that point, we can't really say that anything is a best practice, because the overwhelming majority of what we're doing what is being done and what's guiding things is anecdote. And, one of the interesting things is that the standard for adopting a new practice has changed, or, maybe or at least been suspended for a while. And you heard Scott Weingart yesterday. He was talking about giving low molecular weight heparin to really sick patients because of the thrombotic issues. And he said, my belief is that you should do this. And that's kind of what we have to go on right now, right? And is kind of belief. I mean, we're definitely seeing strong trends one way or another that are help guiding practice. And I want to kind of present a little bit of a different viewpoint than the herbologist. I don't recall his name, who was speaking this morning. He said how, most of what we do is anecdote. I don't think that's exactly true in the emergency department, because we really try to act from data and the highest quality data. But when there's no data, we go down to the next rung, and then the next lowest, and the next lowest, and at the bottom, you're left with anecdote. I mean, well, I guess the bottom is there's no anecdote and you're just flying blind, which is, I think, probably what they were doing in China initially. And I was interviewing a doc from Canada a couple of days ago. His name is Chris Hicks. He's a specialist in trauma and resuscitation, kind of the human factors that go into quality resuscitation. And he phrased it really well, is that we don't have a script for this process anymore. We don't have a script. And that's part of what makes everything that's happening in this COVID era so challenging. I mean, even if you work for a little while in emergency medicine, the unfamiliar becomes familiar. I mean, even if something is unfamiliar, you still have this script that you can apply. Say, all right, this will pretty much work. And you have these countless scripts for kind of everything that you see, and it all becomes system one thinking. It's fast, it's automated. But most of what's happening now is system two. You have to go deep. You have to slow down. You have to really think about it. You have to think about each step, even the simplest stuff, seeing, somebody who's got an ankle fracture, but they also have a fever and a cough. And that goes from system one to system two. And all of that energy and thought adds up. It accumulates at the end of the day. And, those moments, those system two moments are usually outliers, but now that's the norm. That's the norm. Donning, doffing. It's like, okay, am I doing this right? Am I doing this right? It's exhausting. And so what I've been doing, I mean, it's not me, there's a lot of people doing them. You've had a lot of them on this show already, is trying to help emergency clinicians, physicians, and staff write a new script for the new reality. And none of us, well, I mean, I think Weingart's actually writing a script, but most of us are just kind of reporting and filtering all the stuff that's out there. It's all coming at such a frenetic pace, and you just can't take it all in. So we're condensing, we're filtering it, and I'm doing it to your original question, I'm doing it by telling stories and sharing practices, and kind of just presenting the human face of it. So people are like, oh, other people going through this too, and they're doing the same thing and feeling the same thing I am.
Rob, I think that's really interesting. You were talking about sort of the use of anecdote and expert opinion. And I get the feeling that sort of as a group, especially the four of us on this panel, are a little more comfortable with that because of our experience with podcasting and interviewing experts over the last 10 to 12 years, however long we've been doing this now. And we're probably a little bit more comfortable with the current transfer of information. So something that's definitely changed in the last couple months is how we've gotten information to the front lines. And in a lot of ways, it has transitioned to really quick snippets, social media. People are on Twitter. People are using, these ways to transfer information that are not journal articles as much. They're not your standard medical textbooks or lecture, things like that. What have you seen in terms of the transfer of information that has surprised you, and the way that information is being transferred?
I think you said it so beautifully, is that the standards by which we get information, the standards by which information is shared, totally reversed. I mean, this is like the flipped classroom of flipped classrooms. Maybe for better, maybe for worse. And yes, social media, blogs, podcasts, that's where it's happening. I mean, like Facebook and Twitter, I think a lot of people are getting their information from there, or at least it's being filtered through there. And the professional societies are, very slow. They're way behind, they're just putting out micro levels of information when there's so much else out there. The journals, there's some interesting little studies in there. Now more is coming out, but till very recently, the journals were producing anecdote as well. Like, here's our case series of, these many patients, and here's what we did, what worked. Like watching this play out internationally. So China got hit hard, but we're watching that and thinking, all right, well, what's going to happen with, obviously, like the pandemic people knew, but watch this play out thinking, all right, we're not getting a lot of intel. And, since like, okay, it seems to just be all damage control they're doing. What are they doing? Then Italy got hit. And that seemed to be the time when the information or new scripts started coming from both Italy and China. Here's what we're doing. Here's what seems to work. Here's what seems to harm patients. Like seeing, you guys are seeing this, that, okay, what's working? And it's all flipped on its head. Like, be very judicious with IV fluids in these really sick patients. And before, it was this reflex, 30 cc's per kilo a fluid in somebody who looks like they're in septic shock. ARDS, they don't do so well with fluids, but we're just reflexively give fluids. Now it's like pull back. Putting awake hypoxic patients in the prone position. I don't know. Have any of you guys ever done that? I mean, and now that is the standard. And I don't know that it's standard of care, but that is, I mean, just like this virus has spread, I guess this information has spread virally, right? Like that thing, everybody's doing it. I've not talked to an emergency doc anywhere who's not proning awake hypoxic patients. Like these happy hypoxic, everyone's seeing it. That picture of the patient texting with the pulse ox of 50 lying on their belly, that's the standard. I mean, you saw that a month ago, you would have written a case report and called all your friends. Also, another thing that has really been spread through social media, through blogs and podcasts, is a threshold to intubate. At first it was, okay, 6 liters nasal cannula, still hypoxic, you need to be intubated. We need to get you intubated early. Now, well, maybe that's harmful. And so by this type of communication, that threshold is rising because we're realizing, what are the characteristics of these patients? And, I mean, it goes on and on like that, like tents. How are people setting up tents, sharing that information? And the only time I had ever seen a tent was in a disaster drill. And now the tent is the standard. Mild illness, you're still sick and infectious. Once they get in a room in the ER, that room is out for a minimum of 2 hours, and they can also spread infection. So, all right, well, now what's the minimal clinical information you need to make decisions, right? You need pulse ox, work of breathing, mental status. And so it's like this new standard. It's a lot of people have described this and this term as kind of filtered around in the same methods you're talking about, Mike. It's this slow mass casualty. And there's all these different metaphors for it, but I think it really is a slow mass casualty where, all right, what do I need to do for this person right now that if I wasn't overwhelmed, the system wasn't overwhelmed, I might do things very differently. For example, virtual emergency medicine. You have a virtual doctor in the tent, or, hey, I'm going to see you one time in your room. I'm going to talk to you, and you're not going to see me again because I'll only be talking to you through phone or iPad. That's probably a better way to go. I mean, if you think about infection control and use of time. And I mean, so to answer your question, all of those things have come through the non-traditional ways. I mean, people have communicated this way, but where practices are adopted and just hard set in that this is the way we're doing it, and this seems to be the best way.
Rob, so because of that, I think our system is not really built for the speed with which we're having to adjust. The university systems, the big hospital systems, the journals. The 20 minutes ago, we were talking about event medicine and how there are these big leagues that have come to us to ask us to execute on some plans because they went to universities and other places first, and they just can't do it. They're too large and unwieldy. And the same thing with your journal articles. The journal articles, normally their function is filtering, and it's a slow process, but they can't keep up. So people have gone to Facebook and Twitter. And while that speed is helpful, at the same time, it opens us up for real problems. And I've seen this opening. Some people have came into this gap and have put things out there that are clearly not science-based and could be harmful. How do we move with such speed and protect against that?
Yeah, I don't know. And that is the danger when you are acting. I mean, all of this is anecdotal medicine. And I think that an example of what you're talking about would be chloroquine, right? Like that. I mean, a couple of weeks ago, looking at the data, I was super stoked on this. I mean, I think I said on the podcast, if I got COVID pneumonia, I would want Zithromax and chloroquine. I might still want that. I mean, you look at the data, but then there's the other hand, the guys that are the really hardcore evidence-based medicine wonks, and they say, you are not acting on evidence-based medicine. And that's true. But what's the answer when you don't have the data? I don't know. The vetting process has been suspended. And so there are definitely things that are being done that are outside the norm. And right, like with chloroquine, then, people with lupus couldn't get their medication. And, there was a run on it and bad behavior by doctors. So I don't know the answer to that. And that's been, one of the knocks on medical education of this type, right? Is that it's not peer reviewed. But I'll put it back to you guys. I mean, you're putting it into clinical action. How are you filtering that information to separate the wheat from the chaff when none of that has been vetted?
It comes from for me at least, it comes from what expert I'm hearing it from. So my trust in the expert opinion. And then also the thing that I like to lean back on is understanding the mechanism and the physiology of these anecdotes. If it's an anecdote that comes from someone that I trust and I can understand the physiology behind it, I mean, that's my sort of first blush, two criteria that I have to meet.
And I think we have to be very honest that that's what we're doing. That's what's important to me. We know that's not as good a level of evidence as a big trial, because not everything that makes sense physiologically actually turns out to work. So I think that's a great way to approach it, and I approach it the same way, but we just need to be very honest with people that we think this works, and here's my level of confidence, but we really don't know.
I think back to the Las Vegas mass casualty and what those guys did there. And that was just stuff that they thought up in their head. It wasn't like there was some trial for that. And maybe some things they did were great and some things weren't. But sometimes, I mean, as you're alluding to, Matt, you've just got to make the choice and be like, okay, and as you're saying as well, Mike, does this make sense? And then as I start to apply it, is this working? And this is a slow mass casualty where, and it's also quintessential emergency medicine, where you have to make choices based on insufficient data, and you have to make life and death choices based on insufficient data. And that is the nature of the job. I wish it wasn't in this case, but that's how it is.
So Rob, as opposed to the Las Vegas shooting and those types of mass casualty responses where obviously stress is high for physicians and, being faced with just an onslaught of patients and trying to triage appropriately and provide optimal care. Clearly there's a whole other layer of stress for physicians and nurses and respiratory therapists and everyone in the hospital system around COVID-19, just given the contagiousness and the self concerns and concerns for families. What are the stress points you're seeing in docs right now, and any advice for them on how they can address those?
Man, there's a couple answers to that. As far as things that docs are afraid of, I want to address that first, and then kind of in the moment stress points. So one is not knowing the script and figuring out. We were just talking about that, like what does a good script look like? And because there's not really national guidance, we're all sort of writing it. Everyone's writing it on their own. The difficulty working in PPE has been a challenge. People are afraid of getting sick and dying. I mean, what people are most afraid of is infecting their families. Universally, that has been when I've spoken with folks. That as people work in PPE more and this becomes more routine, really less concerned about getting themselves getting affected. I mean, I know I've got several friends who have COVID-19. I'm sure you guys do as well, who clearly got it in the emergency department, but it's spreading to their loved ones. And then so what can you control there is your home decontam process, and just being very regimented with that. Then do you quarantine yourself the entire duration of the pandemic? I don't know. That's a question mark, but that's definitely an anxiety, and you just can only control the things that you can control. That's not going to get rid of the stress, but I think that's one step. But we'll get into a couple other tools in a bit. But I want to touch on something that's been said in this conference several times, and that's that what happening now is it's like this defining moment, and it's exhilarating. And so what the current generation will talk about for years to come. And I mean, all of those expressions of exaltation are no doubt true. But when you break this down to the micro level, the stress and the anxiety, I mean, they have been really significant. And for some folks I'm speaking with, off the charts. And I mean, many docs have anxiety going to work, during work. And I mentioned Chris Hicks earlier, the Canadian doc. I mean, okay, so Chris Hicks, he's arguably, you guys know him, he's arguably one of the world's experts on the cognitive aspects of resuscitation. And he shared a story with me where this was his first intubation of a suspected COVID patient, or they call it, I think, query COVID in Canada. The patient was in respiratory arrest. So Chris has intubated thousands of times. He teaches people how to keep their act together when doing critical procedures. So he's in the room. He's got all his protection on. There's another there, and their processes are great. He's got another doc next to him dictating the protected intubation checklist, right? I mean, you guys, you know how useless checklists are actually when you try to use them on your own. So they have someone next to him. Okay, are you doing this? Are you not doing this? Fantastic. He also has a protected intubation equipment checklist. I mean, he is dialed in. And he's about to intubate, and he's, about to do this procedure he's done thousands of times. But now there are these steps so that you don't put yourself more at risk. And you're also in this really foreign getup of PPE. It's hot, it's confining. You're kind of afraid. It's like there's all of these other things, and he's like pure system 2, pure fear. His prefrontal cortex is shutting down, right? When you're afraid, that shuts down. So Chris Hicks, the master of the human factors, starts to get lightheaded. He starts to lose his focus, and it sounds like he's going to pass out. So what he says, it just sounds like, the tunnel vision's coming in. It's just a lot. And I want to pause for a moment. I will actually get back to Chris in a moment. Speaking with docs around the country, there's all these recommendations like, don't bag the patient, right? So then you have folks getting super hypoxic and about to arrest. I mean, Scott mentioned this, I think, in one sentence yesterday. And it's like, well, I'm not supposed to bag, right? Well, sometimes you have to. I mean, it's like your thinky brain shuts down. So go back to Chris and what he did in this moment. And I think it's a really important exercise. When you lose yourself, you lose your focus of the present moment. You got to find your anchor or anchors. What brings you back to the present moment? What reactivates your prefrontal cortex? So what Chris did was a sequential exercise. The first thing he did was he found his feet. It's like, okay, so what does that mean? I know where my feet are. He knows where his feet are, of course, but focusing on his feet touching the ground. It's kind of a mini meditation. If you're ever feeling stressed or angry or distracted during a procedure, it's a very quick and powerful tool to anchor you back to the present. Where are my feet? What do they feel like? He's still feeling stressed. The next thing he did, he looked at the clock. He had a 1-minute countdown, and he just focused on the movement of that clock. So with their procedure, they wait for 1 minute after the paralytic has been given. This is really common now to ensure that the patient is fully paralyzed so they don't cough on you. So he watches the movement of that clock to anchor him back to the present moment. Next thing is he visualizes the micro steps of his procedure, everything. And then as he's about to do the procedure, he has a kind of a de-escalation word, like a mantra, I guess you'd say. Steady, steady, steady. And all of those things bring him back to the present moment. So there are exercises that you can do in the moment. And if you like, I can talk about, pre-gaming and like kind of how to set up for your shift, how to come home from your shift and mitigate that stress. But in those moments where, during the day, you are in such a heightened sympathetic state already, right? It's not, I think that the expectation can't be, oh man, I'm going to be Gandhi or the Buddha all day and just totally chill. No, your engine's going to be revving high, going to be stressed, and you just need to consider that you'll take it down a micro level. And so that's just one example of an in the moment exercise for coming back.
Rob, you mentioned briefly the concept of pre-gaming and post-gaming from your shifts. And this is something that, anyone who's listened to your podcast, I'm sure has heard a lot about in the past, because this has been sort of your your deep dive for sure. How do you perceive the pregame and the postgame to have changed in the era of COVID-19?
Yeah, so the pregame, yeah, it was a project for a couple of years talking about docs. I mean, yeah, you and I talked about this, Mike, and it was like, okay, how do you get ready to go into your shift? But all of that was based on a known factor, right? Okay, I need to mentally prepare myself this way because even though I don't know what's coming in, I pretty much know what the day in the emergency department is going to look like. And, first I would say that kind of as a general thing, and this isn't like the specific right before you go in, is like connecting with your friends and your colleagues to debrief on what you're doing. And Andrew Weil mentioned this a little bit, like having a friend within a half-mile radius is good for your health. Well, this is great, these like Zoom cocktail parties and the like. And all right, I'm talking to my friend or I'm talking to another doc to debrief. What am I seeing? What am I feeling? The social connection is excellent, but I found that, and just kind of, watching several of these and talking to different docs, the specific discussion about the experience, sort of like the emotional experience for sure, but also like the specifics of the medical stuff seems to be very therapeutic. I mean, it's not like, here's this new thing, like talking about that is therapeutic. But in this case, that has been a tremendous relief or release. So pre-gaming, I think, whatever ritual you have before a shift, whether it's like doing certain exercise or going through a certain mental process, I mean, keep it. I don't think there's any reason to change that. But in this extraordinary circumstance, I think that the first thing to do is to accept, we're talking about like with Chris and in this, your sympathetic state in the emergency department, just accept that you're going to be more heightened than usual. You might not be, it might be just totally chill, but chances are that you will be in a heightened state. But there's a difference between heightened and impaired. So as you do that, check in with yourself. Like, what am I experiencing now? And sometimes there's a component of fear in there. And this is something I got from one of my mentors, Jason Brooks, as a performance coach. I mean, you can think of fear like fear is like a little child tugging on your leg, tugging on your pant leg, telling you that they need something. Because whatever the fear is, like fear is need expressed somehow. So let's just say, so what would you do with that child tugging on your pant leg? I don't know, maybe back in the past, say, shut up, leave him alone, kid. But really what you would do is you'd show compassion, right? And so you feel that thinking, what do you need? What do you need? Now that's easy to do with a child tugging on your pant leg, but it's hard to do with yourself, especially with how hard we are on ourselves. So what if you did for yourself? So rather than judging you that, you're scared or you're anxious or you're, I'm weak, rather than resisting it, you meet it. Yeah, I'm scared. I'm stressed. All right. And in that moment, feeling compassion for yourself, that is step one in de-escalating. And you're not going to take yourself down to zero at all, and it's not going to last forever. But what this is about is revving down that state, conserving energy, and freeing up brain space just so that you can function in the day. And resisting it and just being like, I'm going to grind through this, will just make you feel worse. Resisting it will take your energy that you don't have. And that fear is a part of you. You just have to show compassion for it. And part of getting over this fear is mentally rehearsing and walking through in great detail some of the situational things that are unscripted or part of the new script, like the protected airway. I mean, this is like a whole new paradigm, this whole thing. It's horrendous. Going through that in detail, watching yourself do it helps build resilience, helps anchor you to the present moment, not only as you're pre-gaming, but also when you're doing it. And I mean, there's much more. We're getting close to being out of time, but for the post-gaming,
We've actually, Rob, we've got extra time because Mike Stone is next, and we've decided that his topic is much less interesting than yours.
As
like
usual, that. Rob, I want to make sure that you take up all of my time because you're just far more engaging, and we want more of you.
I like that. Rob, what do you think about the idea before you get to the post game? And I've got a question about the post game too, but if I can interrupt you for a minute while you drink some coffee.
Oh no, that's water. And I just accumulate all these cups on my desk. And it's like, here's another one.
What do you think about the idea of actually performing that mental exercise of going through maybe like the most stressful thing you can imagine in your shift with that, which I think for most ER docs is probably intubating a patient, maybe a crash intubation or a procedure like that. What do you think about the idea of going through that while actually wearing PPE?
I hadn't thought of that. I think that's brilliant. I mean, that's kind of like what Chris Hiss did, which was before he did his intubation, because he was so wigged out by having to wear the PPE and not get infected. And I'm just thinking out loud to answer your question. He rehearsed the procedure so that it had already been done in PPE. I haven't even heard that. And I think it is such a slick mental hack what do you call it? Verisimilitude, or, like making it as high fidelity as possible. Man, it's so high fidelity. I'm actually wearing this stuff.
I think it's interesting to try to put yourself completely, like immerse yourself in the situation as much as possible, because you're right. It's the little things that are going to throw you off, right? I mean, we've done this over and over and over and over again. It's the slight deviations from the mental map that gets you confused and gets you pointed in a different direction. So let's get into postgame a little bit. And I've got a follow-up question about postgame that's going to get a little granular, but I'd love to hear how you're recommending people approach the postgame, and what is a postgame anyway? What does that mean?
Yeah, I mean, pregame gets all the attention, gets all the love, right? It's like, okay, I'm going into a battle, I'm going into this MCI, I'm going into my shift. And it is an all-consuming experience. It's like, okay, how do I mentally prepare for my peak performance? And then you're done and you're kind of depleted, but you're also at this, even on a good day, say 6 months ago, you're still like at this level. And to make the transition to go home, you could just go home. And I'll tell you, man, my post-game was for many years, I'm talking decades, was to like watch TV for 4 hours. My wife can attest to that. And sometimes when I got to 6, it would be bad. And that was just to bring my brain down to a level where I could sleep and just function or feel normal. Cause it's sort of like you just like living in this haze. And a lot of people on this summit or the conference have been talking about breathing exercises. Talking Ben Greenfield about this, and he was doing it. You're talking with Andrew Weil about holotropic breathing. A lot of people talking about breathing. And much of the focus in the ED is on like patients breathing, like, oh, getting oxygen in the prone position, we're going to make your breathing all great. But there's very little discussion amongst clinicians on how they breathe, amongst staff on how they breathe. Now, I think during a shift, it's hard to do a great breathing exercise or routine when you're double masked or in a PAPR or whatever. I mean, you can do it, but I think during breaks, we can talk about that. I think during breaks, breathing can be very effective, breathing exercises. But going home or before you get home, or even before going to bed, or when you get home, sometime after your shift, making that transition. And I mean, there's so many different methods and theories on this, but the way that I like to think of it is you're sympathetically charged when you get out of that shift. Even though you're depleted, your mind's still in a sympathetic state. Hard to take a break, stressful. So I think a down-regulating breathing exercise is what helps. There's a lot of ways to do it. There's no best way. I have done different ways in the past. A breathing exercise that I am liking now for de-escalation, or like a kind of parasympathetic response, is a triangle breathe, which is 5 seconds in, 5 seconds hold, 5 seconds out, then right back to in. That's all done through the nose, in and out. And you feel your belly move in and out, not your chest, not your intercostal muscles, but your belly moving in and out. And it's slow and it's deliberate. And do that for a couple minutes before you get home or make the transition or see your family, or, after you're in the garage and you're cleaning all your stuff. But using that as a transition from sympathetic state to parasympathetic state, to going from, and this is a great analogy I'd heard, or metaphor I'd heard from Dyke Drummond at the Happy MD, going from shields up, right? Nothing can hurt me, to, hey, let's circle the wagons. Family, come on in. We kind of need each other. That might be more than you asked for. But.
No, that's great. That's exactly what I was hoping for, is sort of the mental switch from on, all the stress, find a way to get home without using, alcohol or a bowl of cereal on the couch or, some other detrimental technique to get you back to relaxed. Rob, I do sort of consider you as an encyclopedia of MacGyver type skills within the realm of emergency medicine, just because you talk to so many physicians. And one thing you mentioned earlier sort of spoke to me, and that was this concept of the thing that most docs are most afraid of is getting their family sick. So I've got to suspect that you've talked to multiple docs about what their decontamination protocol is when they get home or before they leave the hospital. And I sort of think of that as part of the postgame. So while we're on the topic of postgame, could you maybe just share with us what you've learned talking to some of these docs about what the best protocol is, or just your perception of what the best concept of the protocol is?
Yeah, it's funny. I have asked a lot of docs about this, and it's all different, and it's all varying degrees of paranoia, which is not a bad thing currently. Like, that's usually has this negative connotation. So I was talking with Weingart about this the other day. Actually, we recorded a show on a lot of stuff that you guys talked about, which is awesome. You guys asked some great questions on here, but I was like, yeah, what are you doing to decontam? And actually his method is good, but I want to bring in a couple other ones that I've heard. So Weingart is a Crocs lover, and I know we're a Crocs family here too, but he got the Crocs with no holes in it, like the hot foot Crocs, like the cooking Crocs. You don't want to drop a scalp on that. So he's got his pair of work Crocs. They're white, the white Crocs too. I mean, you got to, he's such a contrarian and iconoclast. He's got to have the things that just like insult people's eyes the most, right? So white, solid Crocs. So we got the white Crocs at work. That's what he wears. And we heard, I don't know if we heard it in this conference or whatever, but like the big booties, I actually might have been Scott, like the big boots are hard to put on and put off as far as keeping sterile. And so he just wears these Crocs, takes those off. He's got his driving Crocs. He's got his get home Crocs. And so, right. So it's like these 3 steps. I don't know what he's doing in his car. A lot of folks I'm talking to are spraying down their shoes when they get home. And, there's, like alcohol is great. Bleach is great. There's all these, you can find a bunch of different solutions on the internet, spraying down their shoes. The clothing. So what Scott's doing is he's got his scrubs at home. He's got his transition clothes. And then those transition clothes go into one of these, it's probably like a mesh bag, like washable diaper bag. And those go in, his transition clothes go in there. And, then folks have like these decontamination boxes for spraying themselves down. Universally, everyone is taking a shower when they get home. Those days of, doing a thoracotomy and wearing your scrubs to bed, those are over.
Days, I don't
But there's these multiple steps of protection. And so you've got all your hospital stuff that all gets left at the hospital. It's contaminated. You're contaminated. I like the idea of the transition clothing and shoes. That's great. And then getting home, and like those transition moments are where the bad stuff will happen. So you transition into your work shoes, and even those can get cleaned down. I've got a friend who's which I can share with you, who's got pages and pages of how to decontaminate yourself. He's spraying down every surface in the ED all the time with alcohol. Yeah, so I don't have like a best practice. I've just got an accumulation of anecdotes.
Hey, Rob, I got a quick question for you. Do you sleep?
I do, but okay. I'm curious as to where this is going before I give a more detailed answer.
So we were going to have Mike Stone be talking about sleep right now, but you're much better at broadcasting than any of us. So what I wondered is if you would be interested in, and I just got a comment, great question, Matt. So thanks for that from someone from the audience. If you
Wait, now was that. Now you have sort of like the sarcastic biting questions for the other people. Now, was that you say that to yourself, or was that actually someone saying it to you?
No, someone just said, great question, Matt. My question to you is, do you sleep? So I appreciate the positive feedback from the audience. I would like to cover some sleep here, because a lot of the people listening probably more people sleep than our ER physicians. But I would love if you don't have time, totally fine. But if you're able to stay on a few minutes, it's just fun having you discuss these things with us.
Yeah.
Perfect.
And I want to give 2 recommendations on breathing before I go. 2 apps that I really like. I don't have any financial interest in this. One is State Breathing. The State Breathing app. I can't remember who made that, but it has all these different things like relax, go to sleep. So it made me think of it like there's one for going to sleep, one for focus. I did that right before this. There's a kind of like, be present, and one for alert, and just like these different types of breathing. And the other is called Calm, which is, has like a bunch of meditation courses on it, which are awesome, but also has a great graphical guided breathing interface. So Calm and State Breathing. Those are the 2 that my wife and I are using for all of this stuff that we've been talking about.
Yeah, I really like the Calm app. I haven't seen the State, but it sounds really cool. I'll check that out. Do you have anything? I don't want to cut you off, but I want to transition to sleep. Any specific things that you think you really usually have some profound and great thoughts for people? Anything that you would like specifically just to communicate to ER doctors or the other people on here who aren't clinicians but are dealing with quite a bit right now?
Well, there's a lot. I think that there's a lot, and I said this in the conversation, but there's a lot of talk of like, this is our finest hour. This is our finest hour. And yes, this is a finest hour when it's all done. But in the moment, there is tremendous stress and burden. People are pissed off. Is there profanity allowed on this?
Yeah.
People are pissed off because the government effed them over by crappy planning, right? You're hearing that all over the place. Well, we know that blaming doesn't help anything, but now the front line is burdened because of this, or not because of this, but that is helping. And like, people are anxious and afraid. And I tell you, like, don't push against that. Don't push it. Just like, okay, acknowledge that and show yourself a little compassion. We are so hard on ourselves, and like, it's hard to hang out with yourself because you're just like, oh man, you're weak, you suck. Like, why would you feel this way? Now you're angry. It's like, all right, take a pause, take a breath. Got that little child tugging on your leg. What do you need? I got you, buddy. I got you, buddy.
Thanks, Rob. That's awesome. And great advice, I think, for everybody. Matt, you were going to say something?
Yeah, I think the stress that we're feeling, and it's interesting. It's one of the things that we aren't really talking about as much, that a lot of people aren't really mentioning is as ER physicians are going into this, some of them are having their pay cut in half, which is an interesting time. And no one's really complaining about this, because we shouldn't. We have jobs. We're grateful. But as the hospitals, and someone asked the question yesterday, I never answered it because we didn't really want to discuss. They said, why? I don't understand why that's happening. Well, the hospital systems have pushed off all of their elective procedures and things that actually pay a lot of money. And while that stuff's not going on, the hospital systems are stressed financially, and then that's trickling down to those people on the front lines. So I can't speak for firefighters, policemen, ER nurses, and techs. I just know what's happening to ER physicians. So it's a stressful time on multiple fronts. So I really appreciate having someone like you, Rob, too, that we can listen to. That was great advice. I did want to ask you about the Stimulus podcast, where people could go to listen to that. I'm not really asking selfishly because I can't wait to hear it.
So actually the next Stimulus episode will be the art of breathing, ironically. So it's stimuluspodcast.com, or you can just on any podcatcher, Stimulus with Rob Orman. I'll tell you, I've been working on Stimulus for like a year, and then I launched it right when this all hit. And so it's kind of like, well, what are people really paying attention to? But, all my energy is being focused on this education right now. But as people are getting used to it, man, you know what? I'm talking more than the question that you asked, but stimuluspodcast.com or Stimulus with Rob Orman. You might get the economic stimulus package if you search it on the internet, but just throw it into your podcatcher. You'll find it.
Not a great time to be paying for AdWords that say stimulus. Right?
Exactly. It was just like, there's so many missteps in that, but I think that the content is solid.
Well, tell us about your sleep routine before you go, and then we'll ask Mike Stone some specific questions about melatonin, immune function, and things like that.
Man, I'm going to tell you, my sleep has sucked in the past several months. And I mean, part of it for me is that it's like there's so much going on and so much racing brain so before sleep, my wife and I will do that breathing I was talking about. We'll do it from the Calm app. Sometimes we use the State app just to go parasympathetic because there's just like so much going on in the day. Actually, I'd say like a couple hours before that, try to get off all email, social media, or read a book, just slow down the brain and fall asleep. Usually wake up a couple times to pee. 50 just happens. I mean, maybe TMI. And hopefully I can fall back asleep at 3 a.m. If not, I will take a trazodone, 25 milligrams of trazodone to try to fall asleep. If it's really bad, I'll take half an Ambien to fall asleep. If it's a good night, I know it's horrible, but it's like sometimes I just want to be honest with what I'm doing. If I'm thinking about it and I haven't slept well, I'll take.
You know what's funny about that, Rob? Just to interrupt you. The very first person I ever heard report on the increased mortality and the problems with Ambien was you on a podcast one time years ago. So it's just interesting to hear you say that.
On a good day,
do what I say, not what I do.
Yeah. Well, I think you're slanting how the reporting went, Matt. It was. And then, so on a good day, I'll take 2 big magnesiums, the magnesium citrate, great success the next day, and like 2 or 3 milligrams of melatonin. And some nights, I'll just sleep through the whole night. But that's rare.